And I want to begin by honoring our community, our donors, our staff, all our good neighbors, all of you out there who for 2 years now have created a safety network for our most frail elders. Thank you so much for all the personal work you've done, the professional people who are joining us this morning, our home care agency workers, staff in assisted living facilities, perhaps other doctors are on board, nurses, and family caregivers. So this is the first of a series I've started called Aging Wisely, which is something that I'm trying to do myself. And it's a challenge, of course, during COVID, and we'll talk about that as we go along here today. So the format for today is going to be presentation, 15-minute segments, and then Q&A in between each segment. And then I'm going to offer whoever wants to stay on at the end. If Dr. Lynn has to leave and people want to stay on and just chat and check in with me, I will run it as some sort of community support group and try and help you if there's some specific problem you want to talk about as a group and help each other, because we are very good about doing that here at Avenidas. Okay, so this is a full circle moment for me. Just a little story. In 1980, I started my first social work job in Washington, D.C., and eventually worked at a nursing home called the Washington Home for Incurables. And I also worked at a geriatric outpatient clinic through GW. And Dr. Lynn is the first geriatrician I've ever worked with as a social worker on a team. And that was just a few years ago, 1980, 82, 84. And of course, we haven't aged, right? We just look exactly the same, Dr. Lynn. You look
I'm proud of having aged. And so are you.
Right. Okay. So Dr. Lynn is now the busiest person on the planet. So I'm going to just briefly go over her resume and then we'll get going on our topic. So she's a 40+ year geriatrician, educator, quality improvement coach, and researcher. And she's working half-time with Representative Tom Suozzi of New York, who's going to be running for governor in January, on health and aging policy and pursuing a catastrophic long-term care insurance called the WISH Act. And we'll talk about that. And she's also working half-time on data describing, I love this, elder care in counties and advocating for better elder care per county. So I think she's going to talk to us today about Santa Clara County and see how we'll get a report card, see how we're doing. And she's also one of the first hospice physicians, a tenured professor at Dartmouth and George Washington University, a medical officer in the Center for Clinical Standards and Policy at CMS, and director of the Bureau for Cancer and Chronic Disease and Public Health. She's published 300 professional articles and 80 books and chapters, as well as dozens of white papers, court briefs, and guidelines. In addition to her MD degree, she has a master's in Quantitative Clinical Sciences and a master's in Ethics and Public Policy. She's a member of the National Academy of Medicine, a master in the American College of Physicians, a fellow of the Hastings Center and the American Geriatric Society, and a member of the National Academy of Social Insurance. Part of me just wants to ask her, what do you do for fun, Joe? When you're not working, what do you do?
I have grandkids.
Ah, here we go. All right. So we're gonna start your presentation and welcome to Santa Clara County.
Oh, it's a delight to get to be with you all today. And I do have some slides, so let me get them up. And please feel free to put things into the chat as we go along and save up your comments and questions as well. So as promised, I do have some information about Santa Clara County. I know some of you are from other counties, but it's probably about the same for you. And then those are the three topics we're going to take up. How could elder care be better? How could caregiving and caring be better? And why not now? So Santa Clara County, interesting. Medicare costs, and this does not include Medicaid, and it does include what people are paying privately. But nationally, it's about $925 per year for the average person over 65. And Santa Clara comes in at $1,200, 16% higher, which is probably appropriate given your higher cost of living. So that's not hardly eye-popping. But then look what happens when we look at functionally disabled elders, people who are known to have disabilities in taking care of themselves every day or cognitive issues. Nationally, it's about $3,000 a year spent in Medicare. And in Santa Clara, now you're at half again as much. So for every 3,000 spent nationally, you're spending 4,600 per year. And then if you look at those people in their last year of life, someone once said that dying is nature's way of showing you you've been very sick. So it's appropriate that people spend a little more in their last year of life, but look how much you spend in Santa Clara, where you're now 2/3 higher. So Santa Clara has a pattern of throwing a whole lot of Medicare covered services at people who are disabled or close to death, much more than the nation. Obviously, the nation as a whole does that, but Santa Clara does it even better. So you have about 250,000 people over age 65 who are in Medicare. Almost half of them are in Medicare Advantage, and 56% are in traditional Medicare A and B. Among those who are in traditional Medicare, where I can track their expenditures, 25% are in Medi-Cal. So a quarter of your Medicare eligible people are poor enough to qualify for your Medicaid program. And then in traditional Medicare, people who had a physician bill in the year I was looking at, which was 2018, there are about 90,000 people. So that's what the next line is. About 1/3 of them had ER visits, and 60% of the Medicare beneficiaries who you might find in the ER had both of these characteristics. First off, they used home care or nursing home care that was paid for by Medicare, and they were unable to take care of 2 or more activities of daily living. That's like feeding yourself, dressing yourself, getting to the toilet, moving around in your house or apartment. And so this is a substantial level of disability. So 60 out of 100 people who used the ER were elders who were disabled and who needed to use Medicare covered home care or nursing home care. So you can see how you are really building up those high costs. What do we not know? Which it tells us about as much as to our cultural priorities. We don't have any idea how many families face overwhelming burdens, how many have to leave work. A woman who leaves work to take care of a family member loses $300,000 in her own retirement security on average. How many families would go bankrupt? The biggest cause of personal bankruptcy in the country now is serious illness and old age. People who are physically or emotionally overwhelmed, who are often victims or victimizers of abuse, who really hit the wall and just can't keep going, who can't actually move the person, and the person who is disabled gets bed sores. One of the things that's becoming very prominent is that a lot of the caregivers are doing work that's usually done by nurses and doctors. And it's very frightening to be doing this on somebody you love with minimal training. A lot of people are finding they have to move and they may become homeless because of the financial and other burdens. What else don't we know? We don't know how good we're doing. We don't have any idea in Santa Clara County how many people don't have adequate treatment for pain, how many develop bed sores, how many have other symptoms that really could be relieved. What's the waiting time for services? You ought to know that it stays at 0, but maybe it's not. In many places where I've worked, the waiting list for home delivered food is more than 6 months. The waiting list to get on the list for door-to-door transportation might be at least that long. Might be very hard to get speech and occupational therapy, physical therapy. Even medications may take some time. Wait lists for housing is the biggest bugaboo, biggest issue. We're working in one county where the waiting list for disability adapted housing was longer than they were willing to keep it, and that was 5 years. And then the quality of medical and nursing care. Everybody's terribly proud of their medical care until they start actually comparing it to the standards and discover that their medical care is way over intrusive, does not adapt to the person's priorities. We don't even ask about a lot that matters. We don't know how well we're performing. So current elder care is often uncoordinated, inappropriate, costly, isolating. I'm sure you have stories of some of those things happening to you because it's pretty pervasive. We need to improve housing. Why is it that when a disaster runs through, the FEMA tries to, and the people involved, try to rebuild exactly what was there before? Why don't we build a whole lot more single floor housing that's adapted for wheelchair or walkers, housing that doesn't have steps going into it, and it's affordable. You know, a person living alone at 88 does not do well living in a 4-bedroom suburban house. That person really needs to be helped to move into something much more manageable. We need to improve food delivery. We need to improve geriatric medical care so that people understand what it is to build a comprehensive care plan, the geriatric syndromes that they need to know. You go to the average doctor and they're trying to fit you into a disease algorithm. Does this person have heart failure? Does this person have bronchitis? Does this person have asthma? Does this person have cancer of a certain sort? And one of the characteristics of geriatric medical care is that we're also asking, does this person have a supportive family? Who in the family is supportive? Do they have enough financial resources? Are they reasonably prudent about how they could get food in? And what's the panoply of conditions they have and how do they interact? So geriatric medical care is rather different than the usual medical care of a 45-year-old. And then of course there's transportation. I've been in so many communities where people are proud of their transportation system for disabled people until you find that it's basically a voucher system. The person has to be able to get to the bus stop or get to the subway stop. What an elder needs who has mobility problems is really door-to-door transportation. And all of these things have to be coordinated and affordable. We face the prospects of having half of the elderly unable to afford housing, food, and medical care within a decade. Half. So we have to be thinking about how to provide for very large numbers in an affordable way. And that requires that our services be monitored and managed. Someone needs to bear responsibility for knowing how Santa Clara County is doing. And if you don't have enough, whatever, don't have enough transportation, don't have enough housing, taking steps to address those things over time. So we have to use local planning and improvement activities, measure performance and implement the improvements that turn out to be priorities, monitor whether that was effective, and if not, go back and do it again. And then we need to increase the public demand. How long has it been since you saw something in a leading newspaper or on a major television show about long-term supports for elderly persons, other than wringing our hands over how many are dying with COVID? But these things are sometimes there's a plethora of stories that are tearjerker stories, but we need to translate that into what it is that we can do about it. So that becomes very important. So I'm going to stop here and give you a chance to weigh in, and we can do that through the chat. And I think maybe also with people speaking up if there aren't too many voices at one time.
I have a question for you, Dr. Lynn.
Yeah.
I have a question. When you talked about caregivers doing the work that doctors or nurses do, some people don't specifically know about that until it actually happens to them and they take somebody home versus rehab. So let's give examples of what some of those things are. That
I mean, the most common one is running intensive IV, intravenous solutions. So the person comes home with a port, a small plastic device hooked to them somewhere on their arm, on their chest, somewhere. And the family member is expected to clean that, keep it from getting infected, and hooking something up a couple times a day, very often an antibiotic. Kind of scary to take a needle and stick it through and do that, probably with only one time having done it under observation by a skilled nurse. They may also need to change urinary catheters. It is kind of strange to be inserting a catheter into your father's, or especially your
Private
mother's
parts. Yeah.
private
Sure.
parts. So those sorts of things. And then, of course, there are the people who do home dialysis and sometimes much more technical things like having a tracheostomy, which is a hole in your neck. And you have to keep that clean and suctioned and so forth. All of these are things that have to be done by skilled nurses in a hospital or a nursing home. But we give people, 20 minutes at most worth of training and send them home. And good luck.
Yeah, we do have a question on housing, but I want to continue a bit with Medicare and coverage. Regarding how to evaluate a nursing home and a skilled care facility, a lot of people go online to the government website, Social Security, and look at the ratings of nursing homes. What do you think about those rating scales and how are they actually done? Do you have any insight about that?
Yeah, they are very gradually getting better. The things that they can rank on quality measures are not necessarily close to your heart. They do things like whether on average people are losing weight. Well, in general, people getting close to dying do lose weight. So that may not tell you much more than that this is a nursing home that continues to serve people right up to the end of their lives and doesn't just try to displace them when they start getting weaker. The staffing ratios are becoming much more useful. So, I would be really worried about going to a nursing home with a very poor staffing ratio. And that is available. Now, the simple stars menu, yes, a 5-star nursing home is likely to be better than a 1-star nursing home. But boy, all those 3- and 4-star nursing homes, it doesn't make much difference. So you want to kind of dig one layer down, and you can do that on the website. You can see what the citation was for, if there are citations on quality. You can see what the reports out were. The most important thing is, of course, the staffing ratio, but then also just go visit. The place should feel lively. There should be things going on. There shouldn't just be rows and rows of people kind of sitting and staring into space. Persons living with dementia should be, in general, up and walking around until they're very late in their illness. Someone asks, what's a decent staffing ratio? And I've forgotten what it is, but it is on the listing. You should have on the order of 4.5 hours a day of direct care for the average person in a nursing home or more. So you can look at that one also. I don't remember the decent staffing ratio right off, but the standard is listed on the website.
So Bob, the listings are Social Security, Medicare, Dartmouth, and then you go under nursing homes and we could look at rating scales. Another
it used to be called Nursing Home Compare, and it used to be called Home Health Compare, and they've now all been consolidated into one Compare website, but Google will refer you right to it.
Okay. And then I often get questions from my clients about the difference between trainings of the people doing home care in the home through the home care agency, ADL care, and the CNAs in the assisted facilities, and then the CNAs in the nursing facilities. Do you think there's been any changes in the way people are trained over the years?
Yeah, the pandemic has, of course, scrambled everything. The training used to be offered by the nursing home or in some cases by the assisted living. And it was fairly minimal and usually entailed on the order of 30 hours of training and then a roughly equivalent amount of time following somebody around who was doing your job. and then you're considered to be fully trained. In the pandemic, many states, and you'd have to tell me whether this happened in California, but in many states that was abrogated, and you could bring somebody on board with 8 hours of training because it became so hard to get any staff. So this is very hard work. It turned out that many people who were working in nursing homes or assisted living centers got COVID, so they ended up short-staffed. And then they also, with the mandates to get immunized, this was a group that was especially affected by the disinformation about all the fears about COVID immunization. So the nursing home and assisted center staff have been very much less immunized than the residents in these centers. The recent issue has been turnover and short staffing. It used to be that the better nursing homes, you could tell a better nursing home because the staff averaged well over a year of being there, and they had real relationships with the residents living there. Now, many, even of those nursing homes, have turnover rates of 3 and 4 months. And that's really disastrous.
Okay, so we look like we have a question about, and I think maybe we'll get to this later in the talk, about how to reduce the actual costs of long-term care. It has you stated that, and many people here know that the cost of dementia caregiving and non-skilled caregiving for either memory care or assisted care placement or home care, actually in this area can be $10,000 a month or more. Yeah, I mean, you really have to be wealthy in order to be able to care properly for somebody, either through full-time home care or a memory or assisted care placement. And the costs are going up. They're not going down in our area. So you're right about Santa Clara County being more expensive. I get phone calls all the time for people who can't afford long-term care and don't know what to do and want to relocate. So this question is really looking at how to think about reducing costs.
Well, you do have to come to terms with the fact that one-on-one care is going to be very expensive. Even if you said that a minimum salary should be $30,000 a year, if a person needs around-the-clock care, it comes out to 5 FTE to take care of that person if they're taking care of that person alone. Usually, of course, we end up with part-time people, but just think about it as hiring 5 full-time people, because you need 3 shifts a day and the weekends, and then you need some time for time off and for illness, and you need some time for training and for recruiting, and you end up with 5 times $30,000 plus benefits, which comes to $200,000 a year pretty quickly. And you have the cost of the home. So you have to have the roof over your head and the food coming in and so on. So you end up with about $250,000 a year if you don't have any volunteer help. So the question really becomes, how much will your family or your neighbors help out? And people keep forgetting that in saying that they want to stay home, that it is very much less expensive to be in even small congregate settings. So if you're in a setting in which aides can move between 3 or 4 apartments and you're sharing in the cost, you can end up with that $250,000 shared among 4 people or 4 families. And you've extended the very stretched home care personnel. So the same 5 people are now taking care of 4 families instead of 1. These are very hard-nosed issues. And you really can't expect to get away with very low costs in one-on-one care. It's just going to be very expensive, even if you thought that $30,000 a year as a salary was an adequate salary, which I'm sure is below living with a family in your area. It certainly is here. So I think we have to think about things like PACE, where there's a lot of cooperation. It's the program of all-inclusive care of the elderly. pretty much available only to people on Medi-Cal and Medicare. And it ends up being about $5,000 a month. But it's also a real partnership between the family and the program. So the program fills all the gaps and provides respite and provides transportation and provides a daycare center and the medical care and all the co-pays and so forth. But, you know, $5,000 a month is still pretty steep
Right.
for lots of families.
We do have a question for, it looks like, from somebody who's dealing with some of these issues in their own life. So this person wants to know if Medicare covers what you and I know are what's considered the non-skilled needs, but the important needs of somebody who has spinal issues and they're under 65, dress, shower, restroom. So if you're on disability, correct, under 65, I don't think you can get Medicare if you're under 65.
Well, you can, of course, with 2 years of disability.
2 years of disability.
You know, so if you're disabled at the level of 2 activities of daily living or more for 2 years, then Medicare will kick in. But it looks like this person who can dress, shower, and go to the restroom would not have 2 activities of daily living disability. So that person would not get Medicare until they got worse. If they're poor, they might be able to get Medi-Cal, but otherwise, you're right, it's either voluntary assistance or paying for it. And I think that a piece of the answer is going to be organizing communities to help neighbors out. The villages movement is sort of the most visible exposition of this idea, where people in a community kind of organize themselves to help provide transportation, to help bring food in, to help change the light bulb, to help fix the thing that needs a screwdriver, or to get up on a ladder. And you need to really support that endeavor. I think with the internet, it becomes so much more possible than it used to be to coordinate. You know, if people in an apartment building or people in a neighborhood had a way to just say, you know, my daughter usually brings me food, but she's sick and can't go out. Is there anybody who can help me out? You know, and people see that as sort of something that they should do. I think we could get by a whole lot better without having to pay for so much. But we need to organize to do that. We need to know our neighbors.
Right, and it's hard during COVID. Avenidas does have Avenidas Village. We do have a transportation system called Door to Door. And COVID has certainly informed all of us how important these services are and how important we are and how connected we are. And there are amazing people in our area helping each other. So why don't we go on to your next section?
Okay.
And keep sending your questions and we'll get to them.
So about caregiving, people often think that the big issue in long-term care is the medical issue. Not likely. There's a lot of mistaken medical care, but the big issue is having enough people to help out. It is a very difficult job to go into a stranger's home and help them get dressed, help them with a bath, help them go to the bathroom. The people who are willing to do this are often women of color, women who are recent immigrants. They come from different backgrounds. They are not necessarily very familiar with the language of the people they're taking care of or their culture. So it's a very challenging job. And they are dramatically underpaid. Nationwide, the average pay is still about $12 an hour. That's $24,000 a year. That is under the poverty level for a family of 4. And most of these women do have children. So we have really undercut the paid workforce. And then there's the family and the volunteers in the neighborhood. And it turns out that more than half of all care of people who are disabled at home is given for what is called free by family. Let me just say a little more about this. So the paid workforce we have to figure out how to give them an adequate pay and some benefits. In Washington, D.C. here, we managed to get through a much better benefits requirement and minimum wage that kicks in at when people work 30 or more hours a week. The home care agencies run by for-profit entities all split themselves, kept the same staff, and booked them for 29 hours a week, so or less, so they didn't have to do benefits. You just want to scream when something like that happens. This is generally a job that has the highest rate of disabling injuries. It even exceeds construction and mining, because lifting and moving people ends up straining backs. And it has essentially no career ladder. So people who work as home care aides obviously can leave and go do something else, but there's not a way to simply take some more education, to get some further training and get a little bit better job, get a certification as something else. It would seem like it would be pretty obvious that these are people with a lot of skills. People keep calling it unskilled labor. It is very skilled. Dealing with a person with moderate dementia who has to go to the bathroom, it takes a lot of skill, but it's not recognized and not respected. When I first started working in a nursing home back when Paula and I were both there, people would say to me, to my face, "Why would you do that? You had a good education. You're an American doctor. Why would you work in a nursing home? Why would you work in home care?" As if that was just the dregs that nobody would work in unless they couldn't get any other job. If I hear that, what must the aides hear? So the paid workforce is actually the critical link. The paid workforce is going to be wholly inadequate. The Labor Department's projections make this the most rapidly growing need in the workforce in the country. And yet it's going to be very hard to recruit people into this workforce right now. And then there's the family, the volunteers. It is mostly family, but it is also neighbors, dear friends, and so forth. And they provide a lot of support. As I said, more than half of all long-term care services are given in what the government calls for free. It obviously is not really for free. These are people who had to give up work, had to give up their leisure activities, had to give up time with their families, whatever. They obviously provide friendship and inclusion in the community, as well as the specific services. It is almost entirely close family members who provide intimate services. So giving a bath, getting to the bathroom, that's pretty much daughters, daughters-in-law, spouses. There are some sons and sons-in-law, but women end up taking care of aunts and uncles, men pretty much spouses and mothers. It's an interesting gender split. So there's specific services provided, and then there's also the very important element of continuing to relate to the person. Family volunteers really need respite. In most countries, they get an automatic respite for any reason. They don't, it doesn't have to be for surgery. It doesn't have to be for something that, something critical for themselves. They can take a few weeks off to go to the seashore and just get away. And the government will pay for putting an aide into the home for while they're gone. We find that just off the agenda. I mean, you would do that, but people need a break. This is very hard work. And again, many countries find a way to pay people for this work. Not necessarily what they would have earned in their job, but to pay something. And at the very least, to count it as credits toward your Social Security. So a woman who spends 20 years taking care of mother at no pay has all those zeros in her earnings record for Social Security. It would make a difference if instead she had a putative income, at least at the minimum wage. So there are some things we could do if we were committed to doing them. And then the other thing down here is employer flexibility. So most of these people are employed. If they're employed in something that requires that you punch a clock and has no flexibility, then they will have to leave work to take care of mother, even if what mother needed was only kind of standby services for when something goes wrong during the day, or maybe going home for the middle of your shift for half an hour to make sure things are okay. There are employers that deliberately try to make caregiving possible, but we need a lot more of that. And we need it to be dominant in the community. So we need to have Santa Clara County having almost all employers being willing to be flexible around caregiving. Let's see. So we turn to your thoughts on this. How would we improve caregiving? What have you seen?
Okay. Well, if people are thinking about posting questions, maybe it'd be helpful to explain, Joe, that about how home care and caregiving, assisted memory care are regulated, and these policies are set, and the the differences that you call one home care company and they want a 4-hour minimal, another wants 8, another doesn't. I think people are confused about home care in general. If you could speak to that.
There's not a lot of standardization. If you're going to have to juggle home care, you either need to be very lucky or to have some entity like Avenida's serving as your middle person to help you run the gamut. In Washington, D.C. here, everybody requires a 4-hour minimum or 3.5-hour minimum. So if all you needed was half an hour to help get dressed in the morning, tough break, you're going to pay for 3.5 hours no matter what. There is a home care compare for Medicare covered home care. Medicare covered home care is not the majority of all home care, but it is important to use it when you can, because Medicare will pay for 80% of the cost. Most of home care, and for that matter, most of assisted living, is under state and local regulations, which often amount to very little. If it's institutional care, as in an assisted living center, they'll focus on things like the fire code and whether your building has adequate provisions for evacuations, and not whether people are being well cared for. Obviously, it can reach the level of abuse, at which point it's supposed to be reported to Adult Protective Services. Adult Protective Services are massively underpaid, underfunded, understaffed. So most referrals to Adult Protective Services are slow to be followed up on. And unless the person is really in imminent danger, they probably don't have the person power to seriously intervene. We need to fix that. That is the stopgap on serious errors. But you have to expect that it will be expensive and challenging, that people will sometimes fail to show up. They might fail to show up because immigration has caught up with them and they didn't actually have a legitimate status to work. They might not show up because transportation didn't show up or because their car broke down. They might not show up because they decided to work for Amazon at $3 an hour more. So it's a constant juggle to find the right help. If you have to take somebody out of the workforce in your family to provide this help, then that might be better. It's at least somebody but it might also mean really a fraught situation where long-standing frictions arise and where there just isn't enough money or enough respite for people to cope with one another. So it takes a lot of attention to do it well.
That's true. We have a question from Greg. Do you see it, about how to distinguish home, quality of home care, good, better versus less good, poor, or potentially harmful?
No, I mean, the good home care has enough backup to cover for when somebody can't come, has enough protective equipment to deal with COVID, has the skills necessary for your loved one. And those are different. So a person with moderate dementia who is sometimes belligerent and is still walking around requires a different kind of care than this sweet little lady who is so far along that she's bedbound and all she wants to do is to say, dearie, dearie. You know, the care that people need is different. So you have to find a set of caregivers who are attuned to your loved one's needs and who relate to that person. I like the picture here where, you know, there's a hug and it looks like people are actually fond of one another, or at least comfortable with one another. That's hard to achieve, and it often takes some searching around. There is the boundary between adequate care and abuse is a very difficult one. You know, if the person receiving care is someone who sometimes strikes out. I think one of the hardest ones I ever had was a woman who was now in her 90s, who had ridden the buckboards in the Oklahoma land rush when she was 12. She grew up and taught in racially segregated schools. She called my aides pickaninnies. She called them niggers. She was too demented to change. It's really hard to put in an 8-hour shift and to be called those flag words, even though you know that the person is just an anachronism, you know, a dinosaur from another age. It's really hard to be tender when you're being called those names. So, you know, we toughed it through, but it's hard. And so you hope to find somebody who has had some experience, who has a combination of tenderness and tough skin, that if your loved one is a handful at times, they aren't going to get belligerent or walk out or whatever. And that really takes some trial. You know, it's not like you're hiring somebody to, you know, sell spools of thread. It's a very human interaction to take care of somebody with intimate care needs.
I do want to point out to Greg that if these are questions you're dealing with in your situation, or anybody listening, so I am that middle person here at Avenidas, and our website, 3ws.avenidas.org, you can find me, my phone number, email. I navigate these things for people every day on the phone. I help with these discussions, and social workers generally, whether they're with your provider's office or if you're in a nursing home in a skilled care situation, you should have access to a social worker, either in hospice, home health care, ordered by your doctor. And in general, when I was trained, that was part of what we would do. We would be there for you to help navigate these issues, because they're tough issues. And adult protective services right now is swamped. And you're right, Joe, they're not, they come out in a dire situation where somebody is a danger in the moment to themselves or another. And then the police are generally called, and there's a 5150 that will take place, and somebody will end up in the emergency room. And that doesn't happen a lot, but it does happen. And in our area, what is starting to happen, Joe, is I'm getting phone calls from the good neighbors who have the older person who is their neighbor, who's more confused now, and it is at a risk to themselves, but are kind of borderline. So AAPS has shown up and they offer services, and if the person says no, they now leave, unless it is somebody is actually threatening another person or their life is at risk. So it's very hard. Everything's very hard right now during COVID with working remote and restrictions and people being swamped, which is why there's so much burden, as we all know, placed on families and caregivers and each other. Okay, do we have any more questions from folks on the chat line about caregiving? I just wanted to say about agitated folks at home with dementia, UTI, some sort of delirium. Is there any tips to people on about distinguishing what's causing what? Because I think, I know I'm asking you to be doctor now, Dr. Joe.
Yeah, people who have a lot of experience with cognitive failure, you have to learn what works with this person. In general, it doesn't work to fight with them. In general, because you can't persuade them, they're working in a different reality. So, if your mother says, I saw your aunt yesterday, or I see your aunt right now, and your aunt's been dead for 20 years, rather than saying, that can't be, Aunt B's been dead for 20 years, you say, really, what's she saying to you? What's she doing? Engage them in a conversation and then divert them to something else, carry on that conversation for 2 rounds and then say, it's almost time for lunch. What would you like for lunch? Rather than trying to fight over whether seeing Aunt B is really real. To the person, it probably is. A person who's agitated and needs a lot of walking or moving around, you might well set it up so that they get a lot of exercise and really wear themselves out. Don't try to keep them in a chair, assuming that they're stable enough to be walking, but put some handbars in the hallway and encourage them to walk. So you have to kind of adjust to what will work to keep this person reasonably comfortable and to keep the caregiving burden reasonable. You can't have people being hit. You can't have people being assaulted by the person whose mind is going. And people do wax and wane. My mother-in-law, as she died with dementia, suddenly had a period where she could recognize us and talk kind of almost reasonably. And then in 15 minutes, it was gone. So you have to expect that things will come and go and you have to adapt. And that's challenging, but usually quite possible. And it does help some that people become weaker and the agitation period tends to kind of go away. So the Alzheimer's Association has support groups. They are the best around on supporting caregiving generally. Paula may know some better places in your area, but when I'm talking with people just generally across the country, the Alzheimer's Association is the only group that has really reached out to help caregivers. And so they have a lot online. They have a lot in their work groups. Hospice obviously does a lot with bereavement. PACE does a lot with family support, but those are very special programs for only certain people at only certain times of life. I think that's probably as much as I could offer help. You have to be careful about the drugs that doctors will offer. Doctors will offer to give you drugs that will, to use a technical term, schnocker the person and make them much less responsive. Those have a very poor track record. They may be essential sometimes for a short time if the person's just, otherwise unmanageable, but they tend to cause falling, they tend to cause injuries, they tend to greatly diminish the person's ability to cooperate. So I would be very careful about people getting sedatives or tranquilizers in the course of dementia.
We do have a question about the average hourly wage for home care in Santa Clara County, and I'll take that. So what we're talking about are maybe some different types of home cares, because there are the agencies, the home care agencies that may ask you from anywhere in our area, depending upon what it is you need done. You have to remember the wage depends on the type of services you need. So if it's more intensive and for a longer period of time, the cost will be higher. So that can go anywhere in our area from 25 to 45 in hour right now through an agency, but it tends to be more 35 to 45. And they do have minimal hours because the person working needs to have a job and an income and a life. So sporadic hours are not the best way to organize home care through an agency. Now there are private pay caregivers, and the one website that you can find them on is called care.com. But what you want to make sure is that these people have a background check, some sort of clearance, and you want to also clarify all the expectations before they actually come into your home regarding the type of care you are looking for, and that if you want them to be vaccinated and boosted, which I recommend, that is something you can ask for, especially if you're hiring through an agency and you just ask them if they're all their staff or that you're looking for somebody who's vaccinated and boosted, especially if the person you're caring for is immune compromised. That's just a must with everybody coming into your home right now. So, so Joe, there's a question about PACE. What exactly is PACE?
I love PACE. PACE is the program of all-inclusive care of the elderly. It is available to people who are not in Medi-Cal, but it has a financial glitch that I have worked for the last 4 or 5 years to try to get corrected, but it hasn't been corrected yet. PACE operates a PACE center, which is essentially a very active daycare center. Usually has many activities going on, usually separates the people with substantial cognitive failure from those without cognitive failure, and provides rather different arrays of activities. The medical care is in the same building, the primary medical care, usually a physician and a nurse practitioner. They usually provide breakfast and lunch. They may provide supper to take home. They will provide care in the home when a person becomes unable to come to the center, or during COVID, most of the care ended up getting moved to the home. There is a Medi-Cal amount that Medi-Cal pays per month, and a Medicare amount that is paid per month. And so the program works within that income. The Medicare and Medi-Cal amount ends up being around $5,000 a month. And that is actually a bargain for people who need substantial support so that their family member can work. But and as I say, mostly it is people who are being paid for by Medicare and Medi-Cal. If you come in and are not a Medi-Cal person, you will have to pay the Medi-Cal rate, which will be around $3,000 a month. That seems fine for all the services they do and the comprehensiveness they provide right through to the end of life. But there is a glitch with the medication Part D. Medi-Cal pays the Part D costs for people who are on Medi-Cal. For people who are not on Medi-Cal, you must use the PACE program's Part D program. So you are buying into a Part D pool that has only very advanced illness people and is a very small pool. So it ends up being very expensive. It can be over $1,000 a month for your Part D. And that usually stumps people because they've been used to paying $30 or $40 or $50 a month for their Part D. So the PACE program for people who are not in Medi-Cal is very limited by the Part D, I would say, misinterpretation or malinterpretation of the Part D statute. And CMS has the authority to fix this, and so does the Congress, and we just have not been able to get them to do it yet. If they fixed it, then you could buy your Part D on any community plan. It would be $30 to $60 a month, and you'd be fine. But that's the glitch that keeps people who are not in Medi-Cal out of PACE. But PACE is a remarkable program. And I see Paul has answered the other question, and that's how the average wage for the caregiver nationwide gets down to $12 an hour. The average cost nationwide for an agency is almost double that. So the agency is taking about half of the dollars for recruitment, training, supervision, compliance with regulations, reporting their quality data. They take about half of what people are paying.
One of the issues about whether or not you want to hire privately or through an agency also has to do with liability insurance coverage and whether or not you want to be the employer and go the route of reporting taxes and benefits, vacation, if you really need somebody full time, or if you use an agency and they're going to do all that. So that's a choice that each caregiver, each family has to make, and it's based on your resources and your time, because becoming the employer also means that you spend time managing all of that and making those decisions. And then if you use an agency and the person falls in your house, they're insured by their employer. So there's a lot of details here, and this presentation today is I find incredible and important because we're talking about the actual reality and logistics of all these issues we talk about each day and on the phone call when I get phone calls. And Dr. Lynn has been like gallantly in Washington, D.C. on Capitol Hill trying to make change. So are you alone in doing this? Is there a team of warrior doctors up there helping you?
No, I wouldn't say it's robust. We'll get to that in just a second. Okay. I did want to say one thing about the obligation to report your income taxes and insurance and so forth. We have proposed that the area agencies on aging learn to do this, or to find the parties that do it in your community so that you could effectively contract for that. It is a hassle to learn how to withhold money and send it to the IRS and send it to the state taxes and the unemployment insurance and all those things. And it's not very expensive if you're doing it for 1,000 parties, but it's very expensive if each of those 1,000 has to figure it out for themselves. So that would seem to be an obvious thing for there to be a robust way to contract for being able to do that. And maybe there are some companies in your area that do it already, but we've proposed that the area agencies on aging either do it themselves or know who to contract with and have it available at a reasonable price. Let me go on to the next section.
Sure.
So why don't we fix things? The biggest reason is people don't care. I mean, honestly, people simply do not care. It is still the case that half of the people who died from COVID are over 85. And while I find that very troubling, most people find it to be reassuring. Oh, well, those are people we didn't care much about anyway. And now we have as many people dying who are nursing home or assisted living staff as residents, because the residents are well immunized, but the staff is not. And again, who cares? People are not up in arms about any of this. They are not even up in arms. We are not even up in arms about the reliable prediction that half of the elderly at the time they become disabled will be unable to afford food, housing, and medical care. Think about that. Your school teachers, your bus drivers, the people who package things, the people who worked in factories, will never have had the opportunity to build enough of a retirement fund to keep themselves able to support a 20-year retirement. When Medicare passed in 1965, the average age at death was 69. We were insuring people for an average of 4 years. We are now insuring people for an average of almost 20 years. For women, it's even more, for men, a little less. And the average time of self-care disability at the point at which you need someone around, essentially around the clock, is now 2 years of that time. Almost no one has the savings to support themselves for 20 years, including 2 years of needing on the order of a couple $100,000 a year. The average retiree today has $50,000 in total assets other than their Social Security for a 20-year retirement. We have just not faced up to this. We have organizations and leaders who focus on elder care. There are about 100 of them in Washington. They all are caught up in whatever they can get into the Build Back Better bill, which does remind me of a Dr. Seuss book. But the Build Back Better bill is all short term. It is all, can we increase the pay of aides in Medicaid for the next 3 years? Can we increase the requirements for what Medicare, what Medicaid does in the States for 5 years? You know, it's all short term. It's not looking at what we're facing 10 years out. We get all caught up in these various categories that we've inherited from a time when we didn't have this challenge. And they really mislead us, because the fundamental issue is we have a very large number of people who deserve to live reasonably in their old age with adequate support, and that's going to require developing new services and ways of financing it. It is very hard to get Americans to think 10 years out. It is very hard to get them to vote 10 years out. So we have a real deficit in long-range planning. We need to change the politics. We need to, in fact, be concerned about the lifespan. We need, of course, to be sure that kids don't grow up in incredible poverty. It is stunning that half of the kids in the country this year are born in Medicaid. Half the kids in the country are born into grinding poverty. So we need to support kids. We need to create healthier environments for the middle of life. And we need to think anew about the last part of life. Much of it is very good. Much of it, people can still take care of themselves. They can still, be their grandparents or their great-grandparents that they want to be. They can continue to volunteer. They can continue to work. We can continue to work. We can continue to volunteer. But there comes a time when, either from a named illness or just from advanced old age, people become less capable of taking care of themselves and of being, in a conventional sense, productive. We need to develop the ways in which to include those people, us, remember, it's us in the future, into the community, to continue to have them be able to have friends, have them be able to be social, have them be able to have a meaningful life, and enough food and a roof over their head, and the medical care that really makes a difference. Not all kinds of stupid medical care. I hope everybody on this call will write a comment for CMS to encourage them to keep their very limited coverage of this ridiculous dementia drug called Aduhelm, ADUHELM. Go on the CMS website, say comments on Aduhelm, and it'll go right to that page, and say, yes, CMS should only cover it in the context of a study. We have raised the Medicare Part B premium by 20% to cover this drug, which has not been shown to make a difference. This is an example of serious lunacy. So we need some reforms. We need reforms that get well beyond what makes the news. What makes the news are all these polarizing stuff that is not fundamentally fixing anything. So why not now? Go write that note to CMS on Aduhelm. We need to change the politics. Your congressional representative is Anna Eshoo. She has all the right instincts. She's a terrific rep. She's in the Energy and Commerce Committee and the chair of the Subcommittee on Health. Everybody on this call needs to become her very best friend. Take her to lunch. I've helped Tom Suozzi develop a bill called the WISH Act, it's HR 4289, to establish a federal catastrophic long-term care insurance program, which would pay $120 a day to help out when an elderly person lives with serious disabilities for a long time. It would be a supplement to Social Security at the time you need it most. So anybody here willing to help me get to Anna? We need to talk with her about, there you go. Anybody want to join in getting Anna Eshoo? You can pick any of these things. You can pick getting rid of the PACE glitch. You can pick getting better reporting on the quality of home care. You can pick working on the career ladders for home health aides. I'm right now working on the WISH Act, so I'll encourage you to work with me. But you know, if all 40 some people who are on the call would work on getting better policies, getting op-eds in the paper, letters to the editor, raise your voice. We urgently need attention. We will do this right if we focus on it. If we don't focus on it, we will learn to walk away. We will learn to not notice that we have people living in cars in their 90s. We'll learn to not notice that we have people living in tents on our streets in their 80s and 90s. We will learn to walk away, and that will be our future. The one advantage I have in working on elder care is that we're all in it. You can say, oh, well, I'm not going to be that starving kid in the ad and from the Sudan. I'm not going to be that person who has a premature child and many complications. But you can't say that about growing old unless you know you're going to die young and you already have the illness that'll kill you. So all of us are in this together. We're all in a giant roulette game. Some of us will get 10 years of disability. Some of us will get 2 months. We don't know what each of us will get. So what do you want to take up?
Okay, thank you so much for your years of labor for all of us and your years of work. And I appreciate it. I've asked people to start posting questions on the chat line, but we've got 38 people and we've done this before. So I think what we could do, if Kat's with us, our host, is we can ask Kat to come on board and we can unmute everybody. And if we want to have a dialogue and people want to stay on and talk to Dr. Lynn and raise your hands, be respectful of the conversation. So let's see who's staying on. So there's 38 of you. Let's you can unmute. Kat can unmute you, and we're going to see who raised their hands, and we're going to have face-to-face conversation. I think.
Yeah, I think everyone can unmute themselves. If you have a question, please speak up. We're here for you. Or raise your hand too. Go ahead.
In planning for the future, don't we need to, well, let me make an I statement. I think that we need to encourage our children and grandchildren, if they can, to think about exploring private long-term care insurance, which is available today. That is another
I'm working hard on private long-term care insurance. You cannot buy uncapped long-term care insurance now. It pretty much is limited one way or another to around $200,000 in benefits. So it either says we're going to cover you for 2, 3, 4 years, or it says we're going to cover up to a certain amount per day, up to some capped amount. So one of my friends characterized it as you can buy insurance for the kitchen fire, but not for the house fire. Because obviously what you're most scared of is having that 10 years worth of nursing home care. You can't buy insurance now that covers that at any price. It simply isn't.
Well,
gonna work.
that may be true, but isn't it also true that the average person only needs about 3 or 4 years of care on average?
The average person only needs 2 years, right? And you can buy insurance for that much.
And you can buy insurance for 3 years or 4 years, and with some companies for 6 years. And you can, and there is inflation protection that is built in, so your benefit can grow. It used to be 5%. I think some
It is
companies,
5% by law.
right, but you could choose 3%. And so, and it's not inexpensive, but for people who can afford it, it may be a very worthwhile investment. Given that,
You certainly should look into it, and especially if you have those sorts of assets, you should certainly consider buying into it. I'll tell you that I have dropped mine. I had long-term care insurance from when I was maybe 50 to, I don't know, 68 or 69. And it went up 33% in 1 year. And I figured if it went up 33% in 1 year when I was 68, what was it going to do when I was 85 and might really need it? They must retain their funds enough to cover their costs.
right,
And
but when the insurance company wants to raise your premium, you can choose to lower your benefits.
right, I chose $30,000 worth of paid up benefit, but I couldn't keep the policy. I'm just saying, these are the reasons why the long-term care insurance now covers less than 10% of people. And their sales last year were about 120,000 for the whole country. So, it is, if we had catastrophic long-term care insurance as part of Social Security, then there would be a robust market to fill in the space ahead of when the social insurance kicked in. Because then you would be insuring for the house fire and not just, for that middle period.
Right. Well, I agree
yes.
with that.
Yeah,
I agree with that.
That would make long-term care insurance very appealing, and the companies should really jump into it with a lot of enthusiasm. Right now, when you're 50 years old and you're looking at long-term care insurance, you're saying, wait a minute, I took my mother's going through dementia and she's already been 6 years in, and this is capped at 2 years. What's this going to do for me? So people kind of throw up their hands and say, well, this isn't worth it.
Just so
Well,
you know, everybody, I just want to make an announcement, Miriam. We are having a long-term care insurance expert and broker. She does work in the industry. She's part of the speaking in this town hall series, March. The next
Wonderful.
month, it's going to be on solo aging and cost of care. Because partially what I want to do is have kind of a continued dialogue going on the cost of care and what people are experiencing. And in this area alone, I know I do have people who have long-term care insurance, and it's helped them somewhat through the cost of home care and nursing home. But there are incredible issues here overall about the cost. So Miriam, thank you so much for that. Anybody else would like to ask Dr. Lynn a question? This is a unique opportunity to ask a geriatrician DC lobbyist a question. Cindy, good morning.
Hi, I'm very much interested in this WISH Act. Where are you at in terms of getting this passed?
Very early. It was introduced on the last day of June. It's HR 4289. If you go to Tom Suozzi, that's Suazzi, his website, and put in long-term care, you'll come to a press release, and down at the bottom is the actual links to the act and to an explanation of it and so forth. With him leaving Congress at the end of this year, we need new sponsors and co-sponsors and to build a head of steam. So it's early in the process.
Okay, I'm very much interested in that.
Yep. Email me and I'll send you the materials.
Okay, great, thanks.
So, Dr. Lynn, I want to introduce you to Bob Shaw. Hey, Bob, I see you moving. Will you unmute Bob for a second? I want to introduce you to Dr. Lynn. So Bob has created a committee among the Avenidas Village, and they are actually looking at these kinds of issues. And they've started looking at why have a geriatrician as your doctor? You know, a lot of people have had primaries for their whole lives, and the idea of switching to a geriatrician must mean, oh my goodness, I'm older. You know, that's a hard one, right? And then what is the difference in care? So Bob, how's your committee going? I just want you to share with people what you're doing here, and also I want to introduce Joanne to Avenidas and what some of the things we are doing.
Good. The origin of this was a nice presentation last October by Louise Aronson about her book called Elderhood. And that inspired a lot of people to write and say, why don't we have a group? And so we started a group, and we call it Geriatric Healthcare. And we meet about every 2 weeks and have a discussion on the Zoom. The features have been on geriatric healthcare itself. How do we care for ourselves? And one of the interesting features has been a discussion of geriatric doctors in the area and the difficulty accessing them. And it turns out that our 3 key areas, Kaiser, Stanford, and the Palo Alto Medical Foundation, all seem to have geriatric doctors who are available only by referral. And so it's not possible to have them as our primary care physicians. And so we've been trying to figure out why that is and how it takes place and how we can make use of some of these doctors. We have gotten feedback that indicates that, especially at the Palo Alto Medical Foundation, they feel that if they allowed people to have geriatric doctors as their primary care physicians, they'd be absolutely overwhelmed with people coming in and demanding that kind of a service. So they limit their kind of services. But we've looked a lot at what are the kind of issues that we are dealing with from a healthcare perspective, both us as individuals, and it turns out, of course, a lot of us are pretty healthy. And so we're not confronted with a lot of the problems that you just described. But we're just trying to have a forum where we can have discussions of this nature. At our next meeting, we're going to have a speaker who is going to more or less just have a discussion with us. And she is the head of the geriatric group at Stanford Hospital. So we're excited about that, and that's kind of what we're doing with the group. And any suggestions from you would be very welcomed. Thanks, Paula.
Sure, Dr. Lynn, it's Marina Martin who's speaking for them. You know Marina, yeah.
Sure. Yeah. I mean, it's a real challenge. Primary care physicians don't make anything near what other doctors in specialties do, and they are a dying breed themselves. But geriatrics does even worse. So if you're looking around as a medical student or an intern as to what you're going to do with your life, and you look at your pile of debt and you look at the income level of geriatrics, you say, gee, I think I really like ophthalmology. Yes. So, even if you truly love geriatrics and you love the teamwork and you love, working with older people who have marvelous stories to tell and all those things, it still really is the case that it's hard to make a living at being a primary care geriatrician. And that means that we have some of the lowest rates of training people to become geriatrics. And then it's very hard, what the kind of practice that I would most want to do would be with a vibrant team that would include somebody who was really good at social work and somebody who was good at psychology and someone who was a pharmacist, at least part-time, and someone who, again, at least part-time doing various therapies, and that I could stay with people all the way through to the end of their life in every setting. so that I could keep my hand in when they were in the hospital and when they were in the nursing home and when they were back at home. That's what makes it really rewarding. It is very hard to set that up in the current financing and regulatory environment. So it does happen. It is either an older doctor who is willing to not make much money, or sponsored by some entity that sees it to be in their interests to attract older people. So Mayo, for example, has a really pretty hotshot geriatrics program because it helps their referrals. Most academic centers have at least a geriatrics team. They may only take care of the deans and the heads of departments and their mothers. So it's a backwater of medicine right now and not terribly valued. So the average cardiologist makes $550,000 in take-home money each year. The average geriatrician takes home $170,000. $170,000 is not peanuts, but it pales if you have $1 million in debt to get there.
Your comment,
So anyway,
your comment about establishing a team really intrigues me. And how would the individual or a small group such as ours go about trying to investigate pulling together a team such as you commented on?
talk to the PACE programs in your area. They are, if anything, almost over-teamed. They are required to have 12 different specialties at the table in generating care plans. That includes the bus driver, the kitchen people, the people who serve the food, the activities director. As I say, they're almost over-teamed. But the idea of working with a team and having the multiple inputs and the multiple resources is probably reaches its pinnacle in the PACE programs, and there are some in your area.
Thank you.
So I would start there, and then I'd ask them what private practitioners around have basically kind of bootlegged getting this to work. And there'll be some, there always are. They may have a pharmacist that they send their complicated people to, or they may have a pharmacist that comes into the office on Wednesday afternoon and sees all the people with complicated pharmacy arrangements, or does it now by telemedicine. And they know the social workers working as geriatric care coordinators and have hung out their shingles and know which ones do a good job. So they've kind of bootlegged a way to get an ad hoc team. It isn't paid as a team, it's paid piecemeal, in all these different ways, but it ends up functioning as a team, and there'll be some around.
Bob, we could talk about that, because proactive care planning is kind of what I do here. And the idea of teaming with other people to help just within Avenidas, help each other. We have so many experts who are retired that do volunteer time. So I just kind of turned a light bulb on for me about looking at maybe the village in your group as a model for creating something like that, because I do think there's enough conversation now going on in your group that we can extend it to everybody else. So Joanne just posted that PACE stands for a program of all-inclusive care for the elderly. And
I like the property assessed clean energy.
Yeah, I know. Well, it can mean a lot of things, right? This is why we have to Google. This is why we love Google, because we have to clarify what we're talking about. So other people have comments or questions. Some of you I don't know, and thank you for staying on. Anyone else would like to pose a question or a comment?
Let me
Greg.
just say that I really wish Bob Shaw and his group every success, and let me know, how it goes. I think that we urgently need local excellence in elder care that would show the rest of the country what could be done. And you are in an especially blessed area because you have 3 medical care systems to work with that are more than on average community oriented. They are not just private equity privateers. They're deeply rooted in their community. So they have the possibility of cooperating, not necessarily the assured, but it's very different than working with an entity that only is concerned about the return on the dollar.
Well, the medical
And-
school, Dr. Lynn, the medical school and Dr. Martin has partnered with us, and she's now on our board, but the medical students have partnered with me and some of my caregiver groups. And they do among the geriatricians at the Stanford University, they have a partnership program with medical students and some volunteer elders in the community to kind of stick with you through the year. So as we're talking, I'm realizing that one of the things possibly we could cultivate here is I would like to do more community engagement with the Stanford Medical School and those interested in geriatrics. And I think that's something, Bob, you and I can possibly talk about also. And I just want
some of the leaders in innovation in geriatrics are at Stanford. And
Exactly.
you can kind of call them, call their bluff and say, okay, so let's make it excellent in your backyard.
Yes.
Let's not
And
just think about it and put it in journals, but let's
And
make it
Dr.
happen.
Lynn, I do want you to know that I did take our congressional representative to lunch one day. I actually did that 2 years ago. And we talked about long-term care insurance and it's on her plate. So Greg, you had a question. You've been so patient. Thank you.
Oh, no, thank you. And thank you for organizing the session. I very much appreciate it and having the very thoughtful and very, broad look at all the challenges. And I appreciate one of the previous question I had was about how you can measure the quality of care in a way that actually would allow people to put more resources towards the things that are working, because it's very hard to see in any broad sense. You working with individuals can see how it works, what's working individually, but especially when you talk about the teams, how those could be rewarded. But I think one of the things that I cannot figure out is that there is and I have like a foot in both camps, both the technology innovation camp, and you've got people investing billions of dollars into longevity research. And you've got entrepreneurs starting up home healthcare companies. A good friend of mine, has started a support, like a technology company to support that. And you've got people inventing, avatars to try and provide supports at home. And it just feels like there's a complete disconnect between those investment dollars and technology innovations and what actually works on the ground and what's needed on the ground. And I just it's partly a question, partly just an observation that I've seen, but partly a question is do you see any areas where there is a promising interaction between technology either extending or increasing the quality of care or care coordination or something that actually really matters, and that we could develop into something like, I think I've always thought that we could have a center of excellence for elder care, like they have centers of excellence for cancer care, for example. But it seems like a natural marriage in this area would be the technology innovation plus the deep community supports and actually drive us in a good direction. I think it's like Bob is doing, but I'm just curious if there's any examples where you see this actually working.
Just yesterday was announced the new template for interoperability of records. That's a step forward if it works. We need a way that the Meals on Wheels program in your area can know that somebody needs the Meals on Wheels, and that the doctor can know whether the person's getting their Meals on Wheels. The keeping all these things in their bins and not communicating has its serious downside. So that's one technology. There's also just the straightforward technology of better communications that require less skill and that are more reliable. So it becomes more and more possible to monitor how well a person is doing. You can equip a home now for less than a couple $1,000s with monitors to make sure that you know if they've fallen or if they've gotten breakfast and that sort of thing, which would make it a lot safer for people to be at home without somebody checking on them in person. So those sorts of things are happening. I think that the coordination of neighbors is a real frontier. The villages kinds of endeavors really need some infrastructure help so that they can readily do the work that they need to do. And so there need to be, free software and that sort of thing. And it needs to be able to be operated by people who are not, terribly tech savvy. There's a lot of enthusiasm for being able to supplant human help for a person who is disabled. And to have a robot be able to give you a bath, and to have a robot be able to lift you out of bed and put you in a chair. The Japanese have had some gains in this arena, and especially with regard to having persons living with dementia interact with robot pets. So, little robot pet dolphins and doggies and stuff that keep them quite occupied. That's been remarkably successful. But the lifting and moving you to the toilet and so forth, I think a lot of affected people would actually prefer to interact with a robot because it is so terribly embarrassing to have to rely on somebody else to move your bowels. But the successes in that regard have been rather modest. So we shall see how that works out. But yeah, I think that like everything else, there's going to be some set of the needs that are met with technology. And maybe the leader in that is going to be kind of breaking through the isolation and loneliness that afflicts more than half of elders living with disability. People who still could contribute to a book club if only they knew how to hook up a Zoom meeting. Maybe that'll resolve itself simply by people aging into, all of us will know how to do a Zoom meeting, but there are a lot of people who are 90 who haven't even learned how to turn on a computer. And so
there's a lot of effort in Santa Clara County right now towards that, because Senior Planet, which was based out of New York now, also has an office here at Avenidas, and they're one of the first older adults technology program to try. And well, in New York, they did exactly all of that. They wired the boroughs, and they have worked so hard with seniors to get people tech savvy. So now we Santa Clara County, I think, has given Senior Planet and some folks at Avenidas working in the tech, aging, and space initiatives money. I mean, real money to hopefully educate seniors. So it's also a matter of outreach and time and creating those programs. But if anyone is interested in that, I suggest you look at the website and look up Senior Planet and find our local director with Senior Planet, Ryan, or call me and I can hook you up with Ryan, because there is a lot of work going on actually with that, because Silicon Valley, so that particular area is winning a lot of the money here for looking at ways to enhance elder
that would
care.
make sense in your area.
It does make sense. Yes, it does.
Teach us
make
how to
sense.
do it.
I know it's been an interesting career trajectory, starting with you on Capitol Hill in DC in the 80s and now being in Silicon Valley and looking at the changes in everything, and especially in the world of elder care services. So anyone else want to ask a question or make a comment? I mean, I thank you so much for staying on and Joanne for being with us today. All right.
Well, thank you
you
for
so
having
much.
me. It's always fun to talk with folks, and Cindy Schwarting and others, please be in touch if you're motivated to help out on any of these things to change the policies that shape our lives. We really need lots of people to care.
Great.
Thanks so much.
All right. Thank you so much, Dr. Lynn. We'll be in touch. Safe travels. And,
Take care. Bye-bye.
all right. Thanks, everybody.